Hello, my name is Dr. Cheryl Guerrero, and I would like to share a very interesting case that I treated under the supervision of Dr. Gabrielle Thodas during my residency at the University of the Pacific. I have since graduated from UOP and am practicing in San Diego, California. The patient first presented to us as a 13-year-old, 6-month Asian American female with a chief complaint of non-eruption of the maxillary right central incisor and canine. The girl is physically healthy with no known history of dental trauma. A dental exam shows mild occlusal caries. The patient's face is symmetrical and exhibits a slightly longer lower facial third as well as some lip incompetency. Intraoral examination shows a Class 2 molar subdivision right relationship in her permanent dentition. The overjet is excessive at 6 millimeters, with labially flared maxillary anterior teeth. The overbite is 4 millimeters due to a very deep curve of spee with supra-erupted mandibular incisors. The arch lengths were adequate in both arches. The anatomodel showed a horizontally displaced central incisor with its crown rotated more than 90 degrees from normal and its palatal surface facing towards the front of the mouth. This tooth was also dilacerated at the root's apical third in the labiopalatal direction with a crown to root angle of approximately 109 degrees. The apex of the dilacerated root was directly impeding the eruption path of the permanent maxillary right canine. Thus, the horizontal impaction of the maxillary right central incisor resulted in secondary impaction of the maxillary right canine. The axial inclination of the permanent maxillary right canine was relatively upright and normal. However, its crown was in a position palatal to the root of the retained primary canine. A panoramic radiograph confirmed the presence of an impacted maxillary right central incisor and canine. TMJ anatomy is within normal limits, and upper and lower wisdom teeth are seen to be developing. Analysis of the lateral cephalometric radiograph indicates an A and B of 6.6 degrees and a Witt's appraisal of 1.5 millimeters. SNA is increased while SMB is within normal limits. The patient has a skeletal Class 2 malocclusion due to maxillary prognathism with a bimaxillary protrusive facial pattern and slight lip incompetency. So how would you treat this malocclusion? Option 1 would be to extract the retained primary canine, impacted central, and impacted canine, then follow up with prosthetic restorations or implants once growth is completed. This simplifies the orthodontic treatment, but requires the additional costs of restorations. Option 2 would be to extract the impacted central and plan for a future prosthesis or implant after growth is completed. The retained primary canine would also be extracted along with surgical exposure and orthodontic traction of the impacted canine into the arch. This option would extend treatment time, but limits costs to just one restoration. Option 3 would be to extract the retained primary canine, followed by exposure and traction of the impacted canine into the arch. The impacted central would also be extracted, followed by closure of the space and restoration of the right lateral incisor to look like a central incisor. The canine would then be substituted for the right lateral incisor. This option further limits restorative costs to a single crown, but results in an occlusion lacking canine guidance on the right side. Option 4 would be extraction of the retained primary canine, followed by exposure and orthodontic traction of both the impacted central incisor and impacted canine into their proper positions. This option increases orthodontic treatment time, but avoids future restorations. If you are interested in how this case was treated, Please go to the PCSO Bulletin 2016 Spring Edition for more information.